And with this, we'll start with the physiology part. Like if you read physio once, and if you did PVQ, then if you read this, then that is enough. Okay. If you ask me whether things are enough, nothing is enough in this world except the food you get. Okay. So this is enough to score 150. Okay. In physio, there will be around 8 to 10 questions, out of which 5 to 8 questions will be from this period. We'll move ahead with the physiology part. In physiology part, we need to see the first one, which is what? Which is this intracellular receptors and its transport mechanisms. The main one, it is what? It is the transport mechanism. If you see about this receptors and transport mechanism, first about this transport mechanism, if you see, there are different types of transports. One is the active transport, another one is the passive transport. First one, it is the active. So remember, A for active, A for it is against the concentrated gradient. So it is the low to the highest, like it is the flow from the low to the highest point of gradient. And remember, A for A, it is what? It uses energy in the form of ATP. So it uses energy. It uses the energy. So this is what? This is this active transport. And there are different types of active transport. They might use energy, either they may use or their friend may use. For example, in a case of primary active transport, the channel itself or the pump itself uses energy. For example, our hydrogen, potassium, ATPase pump. It uses direct energy or it uses direct ATP and do its work. So it is what? It is the primary active transport. And the next one, it is what? It is the secondary active transport. Means your friend will eat but you will grow. Okay, this is how it is. So first, secondary active transport, it will be coupled pumps. For example, in a case of like sodium amino acids import or any other import which is having sodium in link, and other SGLTs, like for example sodium glutamate transporters for glucose, like sodium related glucose transporters, fine. So these are all the secondary active transport. So they use ATP but not directly, they will utilize the work from the ATP one. Okay. Next, about diffusion part, like there are few transport mechanism. One is this diffusion. If you see this diffusion, there will be the simple diffusion. You know, this alveoli are lined by which of the following type of epithelium? Simple squamous epithelium. Alveoli, it has this simple squamous epithelium. And this is what? This is the simple squamous epithelium. And we know the gaseous exchange in a case of lungs, it will takes place in the alveoli. So there is a simple diffusion. So this oxygen and CO2 diffusion in the lungs, it will be what? It will be the simple diffusion. Whereas in a case of facilitated diffusion, means you need a carrier, means you cannot just go simple. You need a carrier, you need a transport mechanism, you need a metro train, you need a bus to transport this thing. So it is what? It is the GLUT. Okay, it is what? It is the GLUT transporters. Okay, and we know, like if it is diffusing, if you are going randomly, you can go. Whereas we know there is a metro capacity and we know the capacity of a bus. So we know this facilitated transport or this facilitated diffusion will be having a transport maximum. So remember, it will be having a transport maximum. For example, if it is a small box, it can accommodate only 25 people. 50 people cannot sit. Okay. Okay, so that is known as what? That is known as transport maximum in a case of facilitated diffusion. Then about this GLUT, you need to know this GLUT where it is present. First, you need to know it is GLUT 1. It is the 1, remember. Okay, it is present in most of the cells and it is helpful for this basal uptake. So the basal uptake, it will be done by the GLUT 1. Okay, GLUT 1, it will be for the basal uptake. Whereas in GLUT 2, remember that is 2. There is a second alphabet. It is the beta cells of pancreas. So it is the beta cells of the pancreas which has this GLUT 2. We know when there is increased glucose, the insulin will be released, and the increased glucose will be sensed by these GLUT 2 channels, and this causes the release of insulin, and these are present in this pancreas beta cell. Okay, and next one, it is the GLUT 3, which is the neurons which is having this highest affinity. Okay, it has the high affinity for glucose, and you remember this first 3 or not, but you should remember this GLUT 4. If you see this GLUT 4, okay, this GLUT 4, it is what? It is insulin dependent. If there is presence of insulin, then only this GLUT 4 will work. Okay, if there is no insulin, there is no ID card, this GLUT 4 won't work. So it is what? It is this insulin dependent GLUT transporter. It's what? It is the insulin dependent GLUT transporter, and this will be present in this skeletal muscle, cardiac muscle, and the adipose tissues. Skeletal muscle, cardiac muscle, and the adipose tissues. Fine. And the fifth one, GLUT 5, will be present in the sperms, which is especially for this fructose transport, that is fructose uptake. And we know this sperms, they need to motile, right? They should be motile. And for motility of the sperms, it needs some energy. It will get from the fructose. So this sperms, it will use this GLUT 5 to get the fructose, and in intestine as well, so we'll use GLUT5 to get the fructose. Fine. And about this SGLT, as I told you, we already discussed SGLT. They are what? They are this secondary active transporters. Secondary active transporters. And this SGLT are different types. We need to know just SGLT1 and SGLT2. Remember, we have only one gut. Means like this gut is in one entire length, right? Like means there may be small intestine, large intestine, but we know the small intestine has also 3 parts. But it is in one entire length. It's not like duodenum is half cut. Then after this cutting, jejunum starts. No, we just named it. So this one entire gut. So one gut. So it is what it is, the SGLT1. Okay. So it will be present mainly in the intestine part. It is mainly present in the intestine part. It can be seen in kidneys, but in kidneys, you know, we have how many kidneys? We have 2 kidneys. So remember, 2 kidneys. So SGLT2 will be present in kidneys. No, GLUT is a facilitated diffusion. Means GLUT, it is the facilitated diffusion. Just remember. I have written it right. So GLUT, it is a facilitated diffusion, guys. Okay, don't confuse it. Whereas SGLT, it is what? It is the secondary active transport. Fine. And next about this junctions. If you see about these junctions, why it is like, for example, if you are holding someone's hands for the first time, then what it will do? Means you will hold very tight. You won't even get this passage of gas even. So it is what it is, the tight junction. So remember, you are occluding it. So remember, the tight junction, it is made up of 2 things, 2 proteins, which is this occludin and claudin. Okay, you are occluding the gap. So it is what it is, this tight junction. Very tightly you are holding. These tight junctions that will be present in this barriers like blood-brain barrier and the blood-testis barrier, or other barriers where you cannot allow passage of the E substances. So it is what it is, this tight junction. Whereas this junction, which is this gap junction, where there is a lot of gap, okay, here there is no gap. So it is what it is, this gap junction. And if there is any gap, so it is what? It is the gap junction. And gap junctions, they are usually made up of connexons. And remember one thing, if there is any mutation in this connection, it can lead to a disease which is known as Charcot-Marie-Tooth disease. Okay, remember one thing, if there is any mutation to this, can lead to this Charcot-Marie-Tooth disease. A good Dr. Ritika and good Dr. Shanavaska. Got fine. Next, about few more things about this hemidesmosomes. They are present in the basal side. Okay, these are this basal lamina, which will be consisting of this hemidesmosomes. Okay, whereas this intermediate filaments, it will be made up of this desmosomes. So remember, this tight junction, it will be made up of occludin and claudin proteins. Gap junctions, it is made up of connexons. Whereas this basal lamina, you will be able to see this hemidesmosomes. Whereas this intermediate filaments will be seen in a case of desmosome. Okay, these are the few molecules you need to remember. They will ask in question like gap junctions, they are made up of occludin and claudin proteins. Is it true? If you see this gap junctions, it will be made up of this connexins. Whereas tight junctions, it will be made up of this occludin and claudin proteins. Right? With this understanding, we'll move on to the next part. Okay, then if you're able to see this action potential and cardiac action potential, इसमें क्या difference है? अगर आप देखोगे, so this action potential, it will be almost similar to all of these action potentials. लेकिन बस एक फर्क है. There is the only one organ, or this only one part of this organ which is having a different action potential. उसमें क्या different है? So if you see, for every stimulus, there will be a threshold. For example, if someone is keep on mocking you, like first initial days, will keep or you will let it go, right? So if you see, if you keep on mocking someone, okay, there will be this sub-threshold stimulus. So at certain point, like your brother or sister, they will get angry. So that point where they get angry, or at that point where this stimulus will execute as an action potential, it is known as threshold points. It is known as what? It is known as threshold point. About this stimulus, there are like few different points. Okay, for example, it will be having this few different points. Once this stimulus get executed, it will be having this phases like depolarization, followed by this there will be this repolarization, and there will be this hyperpolarization. So what is the universal thing? If you see this depolarization, it will be because of this sodium ions. So it is because of this inward movement of this sodium ions. Fine. Then about this repolarization, it's mainly because of this potassium. Okay, so remember it is like, so whatever we write, so it is the sodium potassium. So whatever we write sodium first, right? So it is what? Sodium is the one which is causing depolarization. So sodium, it causes depolarization, whereas potassium, it causes repolarization. So if you move ahead, you will be able to see the next phase, which is this hyperpolarization. Okay, the initial phases, it will be depolarization, followed by this repolarization, which is because of this potassium ion out, and followed by this there will be more potassium will come out. So it will lead to this phenomenon which is known as hyperpolarization. and finally it come into the resting state. And once it comes to the resting state, then it will start. There will be this small sub-threshold stimulus. Once your brother get angry, it will lead to this action potential, which is causing this depolarization. Right? Okay. Yeah, but yeah. So remember the first ion, it is kya? So it is what it is the sodium. Okay. Then about this potassium, it will be causing this repolarization. Okay. So just go to the pattern. Then we'll move ahead. Then if you see about this potential graph, this is way different. Why it is different? As I told you, this depolarization, it is because of sodium. Whereas in a case of SA node, there is a difference. There is a difference. What is the difference? This depolarization, it is because of this influx of calcium. So in a SA node, the depolarization, okay, the depolarization in a case of SA node, it is because of this calcium. So इसीलिए अगर if there is any atrial arrhythmias, तो हम तब क्या ऐसे दे सकते हैं? If there is any atrial means atrial problems, then we can give calcium blockers if there is any atrial arrhythmias. Yeah, the hyperpolarization in a case of nerve, it is because of this excessive potassium arrhythmia. Okay. Then about this repolarization, it is universal phenomena. I told you it is because of the potassium. It is because of the potassium. Okay. And this happens in the SA node. So in SA node, they will ask you which of the following ion is responsible for this depolarization, and the answer is what? It is the calcium. Right. Next about this ventricles. In ventricles, the same repeats about like that. Like we see in nerves. Like if you see, there is this phase 0. Phase 0 is actually what? It is this sodium influx, which is causing the depolarization. Okay. And next one, it is the, once it causes this depolarization, when it causes this positive peak, then it will start to depolarize. And when it start to depolarize, the starting, it is because of this potassium efflux. Okay, potassium efflux. But the calcium, it won't let it to happen. So at the same time of potassium coming out, the calcium tells no, I will equalize it by coming in. So the potassium will go out and calcium will come in. So it will lead to this phase, which is known as plateau phase. So they will mark you this point, which of the following ion is responsible for this plateau phase. Okay, because we know the potassium is already going out, but this calcium influx, it is responsible for this plateau phase. Okay. Then we'll move on with the phase 3. If you see this phase 3, it is what? It is the repolarization. And हमें पता है this repolarization, it is because of the potassium effect. And after followed by this repolarization, it is what? It is this resting potential. So remember one thing, that depolarization is anywhere, it is because of the sodium, and in SA node, it is what? It is the calcium. Whereas the depolarization in anywhere means in most of the tissues, it is what? It is sodium, whereas in the case of SA node, it is calcium. Whereas depolarization everywhere, it is what? It is the potassium. It is the potassium. Okay, remember. Next about this lung volumes and curve. Okay, and about this lung volumes and curve, you need to know about this first ratio, which is this FEV1 by FVC ratio. Right? If it is normal, then it should be 80%. So first in the question, it will be written patient, yes, yeah, like yeah, a 55-year-old smoker. Remember, it is a 55-year-old male smoker. Okay, the gender bias. The male smoker presents with complaints of shortness of breath. And now you plan to do an investigation which is known as spirometry. And on spirometry, you will be able to see his FEV1 by FVC ratio is 63%. What is the disease you will think of? Is it a restrictive disease or an obstructive lung disease? So it is what? It is this. It is the COPD, which is what? Which is this obstructive type. So remember, with this FEV1 by FVC ratio, we can tell whether this is an obstructive disease or a restrictive lung disease. Okay. So then in a case of normal, it will be more than 80%, or in a case of restrictive lung disease also, it will be remain normal or more than 18%. It will remain normal. Whereas in the case of restrictive lung disease, why this is normal? Because here the FEV1 also will decrease and FVC also will decrease. So since both of them decrease, it will look it is normal. Whereas in a case of obstructive lung disease, this will be decreased. So there will be decreased FEV1 by FVC ratio. Okay, yeah. So you should remember this. Next one, if you see, this is how a normal flow volume loops looks like. If you see this normal flow volume loops, and it is, and you saw this next loop, which is looking almost similar to this, but it is a smaller version of this normal one. It is which disease? Is it a restrictive disease or it is an obstructive disease? Restrictive. Okay, restrictive. And I will tell you how will you differentiate this restrictive from an obstructive disease. If you're able to see this scoop, if you're able to see this type of scoop formation, it will be seen in a case of obstructive lung disease. Okay, they will give this image and they will give 4 options of obstructive disease, like 3 options of obstructive disease, and they will ask you which of the following condition will not seen. For example, they will give you COPD. The following graph will not be seen in which of the following conditions. For example, COPD, asthma, emphysema, and fibrosis. Okay, so it is not in a scene in a case of fibrosis, which is a restrictive lung disease. Fine. And about this one, flattening of this spirometry graph. Flattening will occur based on the obstruction level. Okay, if there is any expiratory, if there is any extrathoracic, flattening of this inspiratory curve, extrathoracic obstruction, there will be a flattening of inspiratory curve. Okay, okay, inspiratory curve. Okay, and if there is any fixed obstruction, it will cause flattening of this both. See here, here there is this expiratory curve also, expiratory curve flattening as well, of flattening. Okay, here you will be able to see what? Here it is because of the any intrathoracic one. Okay, but if there is any obstruction, or if there is any proper stenosis, then it will lead to this or this fixed. If there is any fixed obstruction, then it will cause flattening of this both means both this expiratory and inspiratory curve. Whereas if there is only inspiratory flattening, it is because of, as I told, it is because of extra thoracic obstruction. If there is only expiratory curve for flattening, then it is what? Then it is the intra thoracic obstruction like foreign bodies. Fine. If there is both side flat like this, it is because of the fix. For example, you did an intubation and the patient is intubated for a prolonged time. Then what will happen? This trachea will undergo ischemia. Then it lead to this stenosis part. So in a case of tracheal stenosis, it leads to this both side flattening. Okay, just remember that. Right? By this understanding, we'll move on to the next part. फिर उसके बाद आगे बढ़ते हैं कि sarcomere and molecular motor की तरफ. If you see, mostly what they will ask you, they will give this image and they will ask you which of the protein is responsible for this band, and they will, or else they will ask you, since this image has been given, and they will ask you which of the following band which remains constant during muscle contraction. Okay, first we'll understand what is this sarcomere and how it looks like. If you see, remember, जो भी midline है, remember it is midline. The thing which is on the middle or the midline, it is what? It is the M line. So M line है तो midline है. So M line, it is the midline. So M line, it is the midline. Okay, and adjacent to the midline. So remember, you are joining 2 lines. So if you are joining 2 lines like this, there is a 2 lines and you are joining. So remember, it is H. Okay, so you are joining 1 line, 2 line. So you are joining 1 line, 2 line. Okay, you are joining 1 line, 2 line, and you are joining them. So it is what? It is this H band. So it is forming this H, right? So it is what? It is the H band. So बीच में M line है, फिर 1 line, another line, joining है. So it is what? It is this H band. फिर उसके बाद there are two more zones. Okay, there are 2 more bands. One is what? If you see, there is band which is known as A band, and another one band, it is known as I band. You know, there are few important proteins, out of which we need to know 2 proteins. One is what? One is this actin, another one is myosin. So this actin, it won't goes with A. Okay, actin don't goes with A. So this actin will be present in the I band. Okay, in I band, you will see actin. Whereas in the case of A band, you will see myosin. This I band will be consisting of both actin and myosin. Just remember. So I band में actin रहेगा, or myosin will be seen only in A band. Okay, and after this, you need to know this both of this, the ends of this I band. Okay, it will be connected by this line which is known as Z line. So initially, if you just for this understanding, midline, it is the M line, and followed by which midline adjacent to it, it is known as H zone. Okay, and we have this protein which is known as myosin. Okay, this protein which is what? Which is this myosin, which is seen in the A band. And we know this I band will be consisting of 2 proteins. I band, it has 2 proteins. One is this One is this. This one, it is what? It is the actin, and this is the myosin. Okay, the same myosin. Fine. And if you see during a contraction period, this both I band will come together. Okay, so there will be during the contraction, I band, the length of I band will decrease. Length of I band decreases and A band remains same. This is the thing you need to remember. And if you see, as I told you, the central line, it is the M line, and followed by this small area, it is the H zone, and this is what? This is the A band, which is having this myosin. Then followed by this is this I band, which is having this actin. Then followed by this is the Z line. Okay, this is the Z line. They will mark some of this point and they will ask you which of the following line is this, or which of the following protein is responsible for this, right? Then you need to know about these two molecular motor proteins. One is this known as actinin and another one is known as dynein. Okay, actin, now kinesin and dynein. Okay, or kinesin also known as, which is causing this anterograde. So remember, this kinesin will cause us this anterograde. So what is the importance of it? Anterograde transport in the axons. And next one, it is the dynactin. Okay, remember dynactin and or dynein. Okay, dynein. In dynein, remember this dynein will cause us this retrograde. So remember, R for R, dynein causes retrograde transport and it is responsible for transferring the rabies. So rabies, R&D. Remember, rabies and dynein, R&D. Rabies will be responsible, will be transferred via this dynein protein, via this retrograde transport. So it is the rabies virus which goes like this. Okay, we know this rabies will involve this retrograde involvement. Okay, itna to pata hai na, right? And we know in a case of rabies, what is the name of the bodies you will see in a case of rabies? Pathologically, what is the name of the bodies you will see in a case of rabies? I will see the Negri bodies. Negri bodies we seen in a case of rabies. Fine. Next, about the movement of the GIT. We see about the movements. You need to know about this peristalsis, segmental contraction, and MMC. Okay. So there are few different movements. You need to know first movement, which is what is this peristalsis. And we know this peristalsis, it is responsible for pushing the food. Remember, peristalsis, we won't care about the absorption part. We need to transfer this food. We need to transfer this food from here to here. Okay, so for this, what we'll do? We'll do two phenomena. One is what? One is this contraction part, and another one is the relaxation. Because if both side is constricting, how this food will move? So one side will be constricting, another side will be relaxed. Okay, relaxed. So what they will ask in this part is this: which of the following component is responsible for relaxation during this peristalsis? So if you see the component for causing the relaxation, so see, if you are not a VIP, then there will be no relaxation. So remember, if there is no VIP, so remember the relaxation causing things, they are this nitrous oxide and the vasoactive intestinal peptides. So remember, it is no VIP. So it is the relaxation. Okay, relaxation. It is the no VIP. Whereas for contraction, you see it is this acetylcholine, IH3 and the substance P. So remember mainly about this acetylcholine and the substance P. Acetylcholine and substance P, it causes the contraction part. So it will cause contraction with acetylcholine and substance P, whereas this relaxation, it will be done by this nitrous oxide and the vasoactive intestinal peptides. Fine. And if the same occurs in this opposite direction, we'll call them as vomiting. So vomiting will see this antiperistalsis. And about the next one, which is this migratory motor complex. Okay, so because as you are hungry, then your stomach will be having the few movements. Okay, so this is known as what? This movement, they are known as migratory motor complexes. They are known as migratory motor complexes. And this migratory motor complexes will happen to erase or will happen to clean the stomachs or the bowel. So it is known as what? It is known as migratory motor complexes. Yeah, good, Dr. Sharnavaskan. And this MMC help in the cleaning of bowels before a meal. Okay, before a meal, you will be having them sounds, right? So it is this MMC, and this usually happens around 9 to 100 means about after 90 minutes this MMC will start and it will happen, okay, and it will happen and roam around after every 90 minutes. And once food comes, this MMC will decrease and it will promote the peristalsis. 5 centimeter per minute it will move for 5 centimeter. Next, about this one more movement, as I told you, peristalsis, it will just move ahead, it will just moving the food particle, whereas there is one more phenomena which is known as segmentation. There is one more phenomena which is known as segmentation. Or segmentation, remember, like this food which is being propelled by this peristalsis, it should be absorbed. So for absorption, what you will do, you will have this food and this bubble will come and it will cause contraction and it will cause absorption. So it is known as what? It is known as segmentation. It is known as segmentation, and segmentation, it is for absorption of the food. And next movement which is known as mass movements. For example, all our defecation movements, it is what it is, this in mass movements. All the bubble, it will react quickly. So it is known as in mass movements, which is seen in a case of defecation reflex. Fine. And there is one more reflex which is known as gastrocolic reflex. In question, they will reflex. There is a small child which goes to toilet, okay, or like especially fecal, okay, after a meal, like just you feed a child a meal and the child now you need to use the toilet. So it is what? It is because of this reflex which is known as gastrocolic reflex. Once this food comes and reaches the stomach, it will cause relaxation of the sphincter, and this is known as what? This is known as gastrocolic reflex. It is most commonly seen in children's. Fine. And next, about this J hormones and secretions. And if you see about this J hormones, there are different families. One is known as gastrin family, another one is known as secreting family. So in the case of gastrin family, if you see, there will be two hormones, gastrin and 𝗔𝗔𝗀. Gastrin and 𝗔𝗔𝗀. We know gastrin, it is responsible for secretion of HCl. Okay. What is the name of this? Gastrinoma, means HCl secreting tumor, which is known as gastrinoma. It is associated with a syndrome. What is the name of the syndrome? It is what it is known as Zollinger-Ellison syndrome. Okay. So Zollinger-Ellison syndrome, it is what it is, the presence of this gastrinoma secreting tumor. Most commonly, it will be seen in a triangle which is known as Pezzaro's triangle, and most commonly it is at the duodenum. Okay, duodenum, and it is a gastrinoma secreting, and there will be more acids. Okay, there will be more acid secretion, so there will be a formation of ulcers. Fine. And 𝗔𝗔𝗀, it will causes what? It will causes this gallbladder contraction. Once you have a fatty meal, then it will be lysed by this biles. So it will be lysed by this biles because of this 𝗔𝗔𝗀, cholecystokinin. It will causes this gallbladder contraction. Right? And next, about this secretin family. In secretin family, we have the secretin, which will be responsible for secretions in the small intestines like duodenum, and we have this vasoactive intestinal peptides, also causing the secretions for absorptions and also GIP. Okay, all of these three will be come under this secretin family, and we know in a case of 𝗵𝗵𝗻, there will be a diarrhea will be presenting. Okay, like achlorhydria means there will be absence of HCl, whereas in a case of Zollinger-Ellison syndrome, there will be more acid. Okay, just remember those things. Next, just remember the most acidic secretion kya? It is what it is, this gastric secretion. Okay, whereas most basic one kya? Bonner gland, because we know once there is a food into the stomach, it will be digested by these acid secretions, and once this food, it will move into this duodenum, then this acid cannot enter the duodenum, because it can cause which one? It can cause this gastric ulcer, like, or this peptic ulcer disease, which will be causing this duodenal ulcer. So to prevent this, we have a gland which is known as Brunner's gland, which secretes this alkaline pH1, will secrete this alkaline pH1. Fine. I guess you are getting it, guys. Next, simplest question. Okay, the simplest question which will ask in the exam, but make sure you are getting it correct. So one of your main motto of your examination is not getting the tough question correct, because tough questions will be 10 to 15 questions or maximum up to 20 questions, whereas the easy questions, it will be 150 to 180 questions. So main motto of your exam is to get easy questions to be correct. Okay, अगर आपने easy questions को आपने correct कर दिया, then you will able to come out with flying colors. तो आपका मेन मकसद यही रहना चाहिए, जो भी इजी क्वेश्चन पूछेंगे उसमें बिल्कुल गलती नहीं करना. Like if there is any easy questions, you should not miss it, you should make it correct, right? And there are different parts of the nephron. The parts of the nephron include PCT, the first part, here it is the glomerulus, then it is the PCT, followed by this there will be this loop of Henle. There will be two loops, descending loop and this ascending loop. Okay, descending loop and ascending loop followed by this distal convoluted tubule, and followed by this there is a collecting duct. Okay, this is the sequence. Okay, there will be this PCT, loop of Henle, and DCT, and collecting duct. Now in more advanced, what they will ask is where there is a maximum water absorption, where in the collecting duct or proximal, where there will be a maximum absorption in if there is presence or absence of aldosterone. This is what it is, the PCT. So if there is presence of aldosterone, it does not matter. So the maximum absorption of water, it will takes place in the PCT. So it will takes place in the PCT. So PCT, it will absorb the glucose, amino acids, and most of the ions, and the water as well. It will absorb maximum water. Fine. And next, if you see about the loop of Henle, this loop of Henle, it is responsible for one mechanism which is known as counter current multiplier. Okay. Once this comes, initially the water will go out. Okay. Then they will, because of this water going out, there will be increase the sodium inside the loop of Henle, and this sodium, it will causes this hypertonic, and this will causes this high concentrated. So this is known as counter current multiplier system. So this counter current multiplier, it will be done by this loop of Henle. Whereas this, after once it being multiplied, or once you got this counter current multiplication, someone should maintain, right? So this counter current system, which will be maintained by this vasa recta. So the vasa recta will maintain the counter current, which is known as what? Which is known as counter current exchanger. Counter current means we are making this urine, or we are making this inside, which is more concentrated. So it is known as counter current system. Okay, just remember, that is the thing. Okay, so mostly they will ask about these parts and about the absorption things and water absorption here, as I told you, then about this counter current multiplier and counter current exchanger. Okay, and after this we'll move on to this RAS system. And next, about the RAS mechanism. About the RAS mechanism, you need to know, like when there is a feature of this hypotension, this RAS mechanism activates. So they will ask you what is the origin of these components. For example, angiotensin, it will be secreted from the liver. Remember, angiotensin from the liver. Next, renin, it will be released from the kidney. Angiotensin from liver, renin from the kidney, and this enzyme, which is known as angiotensin converting enzyme, will be from the lungs. Angiotensinogen will be from the liver, and it will be supported by the renin, and it will convert into this angiotensin 1. This angiotensin 1 will be converted into this angiotensin 2 with the help of angiotensin converting enzyme. And this angiotensin converting enzyme, it will come from the lungs. Fine. So once this angiotensin 2 comes in, it will cause few mechanisms. One is what? One is angiotensin. The name itself tells it causes stents to the blood vessels. So it will cause constriction to the blood vessels, and it will increase the BP. It will cause tension, and it will cause increase the BP. And what else it can do is that it can stimulate this adrenal gland, and it can make release of this aldosterone. Once it stimulates and releases this aldosterone, what will happen? Then this aldosterone will come and act to the collecting duct, and it will absorb this sodium, and we know wherever the sodium goes, it will absorb the water. So it will cause, first one, it will cause tension to the vessels. Next one, what it will cause? It will cause sodium and water reabsorption from this collecting duct. Then next, what it will also cause? It will cause increase the thrust. It will stimulate the thrust center, and it will cause more thrust, so that it will drink more water. Wherever sodium goes, the water will always follows it. Remember, okay? So this is how this RAS mechanism works. But in pharmacology, how they will integrate is that, you know, this angiotensin, it will cause constriction to the vessels, and it will cause hypertension. So we can use as a treatment, right? If you block this angiotensin, or if you block these receptors, or if we block any of these enzymes, then it can be used in a case of hypertension. So they will give this chart, like we told, this angiotensinogen, it will be from liver. Okay, fine. Then this renin, okay, this renin will be from kidney. So these two will come and will combine and will form this angiotensin 1. So if we block any of this above, then there will be no angiotensin, and if there is no angiotensin 1, then there will be no angiotensin 2, and it won't go and act, right? Okay, so this drugs which act on this kidney, they are known as direct renin inhibitors, and followed by which I told this enzyme, which is ACE from the lungs. Okay, from the lungs we'll get this ACE. So if there is any blockers for this ACE, like prels, if we give, then it will block, then there will be no conversion as well. Then we have blockers which will block this receptor as well, and will be blocking this degradation, which is known as what? Nephrolysers So they are known as ARNIs. Okay, and we can even go and block to the receptors directly. They are known as angiotensin receptor blockers. Okay, and as I told you, what are the how it will do? It will cause this vasoconstriction, and if there is no vasoconstriction, the blood pressure will drop. Okay, fine. Next, it will stimulate this thrust center. Now, if there is no thrust, there will be no water intake. There will be less water intake. So less water intake means less volume in the blood. Fine. And next one, it will cause the sodium and water retention. And if there is no sodium and water retention, there will be less blood volume and less blood pressure. Nice, yeah, guys. The prill drugs like captopril, it will be what? It will be this AC inhibitors. Whereas renin, like aliskiren, like they will be having this aliskiren, they'll be having this ren or ren in their ending. So they are what? They are this direct renin inhibitors. Valsartans, they are this ARBs. Fine, they are the ARBs. So these things you need to remember. Next one, we'll see about few nucleus. Okay, there is just few more slides, then we'll be done. Okay, there's this. We'll see the nucleus. So to remember about this nucleus, just remember about a car. So you see, you passed your FMG examination. So what you do? You ask your father, like, Papa, मुझे एक गाड़ी चाहिए. Okay, you asked your father. So you bought. So he bought you like a decent car. Okay, he bought you a decent car. So once you bought a car, like you want to have a trips with your friends who have done with their FMG examination. So all of you guys passed. So you are going for a trip to Goa. Okay, Goa or Manali. Okay. So if you are going for a trip, like obviously one will be driving, and there will be some other doors, and in which you and your friends will be sitting. Okay. See. Okay. You and your friends will be sitting. Okay, yeah, imagine this scenario. Fine, there will be in a car, you know, like this small understanding, there will be this radiator. So radiator, it is the cooling. So if you see this anterior nucleus of this thalamus, anterior nucleus, it is for this cooling of body. Okay, it is for the cooling of the body. Fine. Next one, you saw this posteriorly will have this exhaust. Okay, this exhaust will be having this hot air, right? So the posterior nucleus of this hypothalamus, it is responsible for heating. So posterior is responsible for heating, whereas anterior nucleus, it is responsible for cooling. Fine. Then if you see this three people, I told you, right, you are 4 friends or 5 friends you are going here. There will be a person who is sitting in the middle, and 2 of them they are sitting on the window side. You see, who are sitting on the window side, they can explore a lot, right? They can explore more, and they can buy whatever they want. So they will eat more. So remember, they will eat more. So if in a case of sitting side, we will call them as lateral. So lateral nucleus of this hypothalamus, it will be having this 2 centers, which is known as what? Rest center and hunger center. So they will eat a lot, they will puke a lot, and they will drink a lot. So remember, so the lateral one, they can eat. Whereas you are sitting in the midline. Okay, you are sitting in the middle. So if you are sitting in the middle, means they won't give you good, right? So you should keep calm, and you should tell yourself, no, I am not hunger, like I am not having any hungry. No, I'm enough, I'm satiety. So the medial nucleus, it is responsible for the satiety. Okay, the medial ventromedial nucleus, it is for the satiety. Fine. You see, like you bought a BMW car, right? Obviously Maruti 800 mein to upar chhat to nahi milega. So you cannot get 800, you cannot get this shield from this Maruti 800, whereas you bought a big BMW dude, right? So you will able to see while traveling, you will able to see the sky, right? Once you see the sky, you can feel it. So if you're able to see this, whether this is day or night, it is what it is known as circadian rhythm. So this circadian rhythm, it will be by this suprachiasmatic nucleus. So it is the circadian. It is the supra, it is above you. So this suprachiasmatic nucleus, it is what? It is the circadian rhythm. Okay. And don't forget this mnemonic, which is known as SOAP. SOAP. So remember, this supraoptic is responsible for secretion of ADH, which is the vasopressin. Whereas you just read it in opposite. Whereas paraventricular, it is responsible for oxytocin. It is responsible for oxytocin. I guess you are getting it right. So these are the mnemonics to remember. Remember the medial one, who is having always satiety. So it is what? It is the ventromedial nucleus. It is responsible for satiety. Whereas the lateral person who is eating and drinking a lot, it is what? It is this hunger center or thrust center, which is seen in this lateral hypothalamus. Anterior, it is responsible for cooling, whereas posterior, it is responsible for heating, and in suprachiasmatic nucleus, it is for what? It is for your circadian rhythm. Next, फिर उसके बाद आते हैं just about this nucleus of the thalamus. Just remember, it is remember as very VPM, very painful mouth. Okay, so remember the pain sensations of your mouth and the face will be carried by this VPM, ventro-posterior-medial nucleus, whereas this lateral one for this limbs, very painful limbs. So remember from the limbs it will be what? It is the VPL nucleus. It is the VPL nucleus. Okay, बस ये दोनों याद रखना. फिर उसके बाद आगे बढ़ते हैं. Then you need to know this two, medial and the lateral. So याद रखना, like medial for music. So music के लिए तो सुनना. So remember this medial one, it is for what? Is for music. So for auditory impulses it is the medial geniculate body, whereas for this lateral geniculate body it is for the vision impulse. Okay, just you remember this 4 for the thalamus part, then it will be done. And next about this cardiac cycle. Okay, it is one of this, sometimes it will feel like it is very much complicated and things, like let me tell you, don't think as a complicated part, just इसमें थोड़ा बहुत याद रखो, so that if they ask you some point you will be able to remember it. See, if you see initially whatever point is there, this is the pressure and this is the volume. Okay, pressure and volume. So see, there are only two curves, one is this curve and another one is this curve. Okay, if you see, this is the volume. If you see the volume of this ventricle, so mostly it happens in the ventricle. If the volume of the ventricle is increasing, then it is what? It is the ventricular diastole. Okay, in the case of ventricular diastole क्या होगा? The volume of the ventricle will increase. फिर उसके बाद जैसे उसका volume will get increased, then what will happen? Then it will go for what? It will go for the systole. And there are different ways of systole, because we know the aorta will be having a more pressure, and there is some threshold. We need more pressure to open up the aortic valve. Okay, so what we'll do, there is a volume, but हमें क्या करना है? हमें pressure बढ़ाना है. You need to increase the pressure. So the first phenomena in a case of systole क्या है? It is what? It is the isovolumetric contraction. Here the volume remains same, whereas there is a contraction. Because of this contraction, there will be a increased. There will be what? There will be increased pressure. When there is this increased pressure, which is more than the aortic level, it leads to this phase which is known as ejection phase. Now the blood will eject from ventricle to the aorta. जैसे blood ventricle से aorta में जाएगा, means when the blood from the ventricle, it will go to the aorta. Okay, then it will happen what? Then the pressure will decrease. Then it will lead to a phenomenon which is known as isovolumetric relaxation. Okay, so if you see this, so if the blood need to go, then the valve need to open, right? So aortic valve need to open it. Okay, and before this aortic valve open, there is one valve which is closes, which is what? Which is the AV valve. So the first thing happen, it is what? It is the AV valve closes. So once this AV valve closes, it will produce this S1. So first the ventricle will be keep on filling. So there will be this ventricle will be keep on filling. Once it filled, the AV valve will get closed. You will get S1. Once you get the S1, then the ventricle, it need to increase the pressure. Once it will get increase the pressure by isovolumetric contraction. जैसे वो pressure को बढ़ाएगा, फिर once this pressure will increase, it will be more than the aortic pressure, then the aortic valve will open, the blood will go into the aorta. But जैसे aorta means सारे blood हो जाएगा, when all the blood will pass by, then this aortic valve will close. So this aortic valve will close, will cause which heart sound? When there is a closing of this aortic valve, it leads to what? It leads to this S2 heart sound. It leads to this S2. Okay, it leads to the S2. Right? Here you will be able to see the heart sounds. And after S2, then aortic valve opens, then the blood fills. So just remember to see these two graphs of this ventricle volume and the ventricular pressure. It is because of the closing of the valves. Heart sound, it is because of the closing of the valves. Like for example, when you open a door, like just imagine, when you open a door, does it sound makes, like for example, you are coming to your home at 12 a.m. in the morning, where you will get caught while opening or closing. Like while closing you will get the sound, right? So while closing you will get the heart sounds. Okay, and sometimes they will ask you what is the sequence of these events in relation with this JVP, in relation with this ECG and along the cardiac cycle. So just remember by this mnemonic as P. The first one to come, it is the ECG P waves. Okay, it is because of this atrial contraction we know, and then the A wave in JVP, which is also because of the C. Then there will be this ventricular contraction, which is what, like, then there will be this initial QR in the ECG, then followed by this S1, then followed by the C wave, which is because of this isovolumetric contraction, cusp bulge, and followed by this X descent, and it is then the ventricular depolarization. Then there will be this S2, then the V wave, then the S3. Remember, this is mnemonic PA QA1 CX P2 V3. Okay, just remember. It means sometimes they will ask you what is the sequence of this waves. Like for example, P wave, A wave, QRS complex, then first heart sound, then C wave, then X descent, then T wave in ECG, then second heart sound, then V and then 3. So just remember this. Okay. Then about few extra aids. So they will ask you like what are the things you will use to estimate this volumes. For example, if you want to measure the water, then you will use water. You will use heavy water like deuterium and tritium oxide or aminopyrine. You will use these three ones, which is deuterium, tritium oxide and aminopyrine. And about this ECF measurement, we'll use, remember, ECF extra. Remember, in childhood they told going outside, it is a sin. Who told mostly? Our mom will told. So remember, it is a sinma. So the ECF will be measured using this one, and so remember it is sinma. So remember, sucrose, it is used for ECF evaluation, I for inulin, and N for sodium, like radioactive sodium will be used, and Ma for mannitol. So sucrose, inulin, radioactive sodium and mannitol, all of this will be used for measuring your ECF volume. And for plasma, you will use this iodine labeled albumin or Evans blue. So remember this for plasma measurement, you know there is a plasma protein which is what is albumin. So we'll use radio labeled or iodine 125 albumin and Evans blue. Fine. These are the things, just remember in sec. Fine. And about this next part, this is respiratory. You just remember this one mnemonic, just for bore. Okay, remember bore. So in a case of right shift, remember right shift. For right shift, remember as bore. So why it is bore? Because we know it is known as Bohr effect. Okay, Bohr effect. So remember, it is Bohr's effect. If it is Bohr's effect, there is a R. So Bohr effect, it is seen in a case of right shift. And in right shift, everything will rise except pH. Except pH, everything will rise. So there will be increased rising of PCO2, rising of hydrogen ion means if there is increased protons, then there will be a decrease in pH. And there will be increased 2,3 DPG, and there will be increased temperature. Yeah, Dr. Ambika, okay, fine. We'll repeat this cardiac cycle after once I complete this. Okay, just have a patience. Okay, yeah, fine. So there will be this increased PCO2, and you can also remember R for R, it will cause release of oxygen from RBC to tissues. Okay, because the work of RBC is what? It is to carry the oxygen. So once it carries, it need to release into the tissues. So if it releases the oxygen, if RBC releases oxygen, it is known as Bohr's effect. And in Bohr's effect, everything will rises, like PCO2 will be more, protons will be more, 2,3 DPG will be more, and temperature also will be more. Whereas it is opposite of left shift. Okay, it is opposite of left shift. It is known as Haldane effect. It is known as Haldane effect. And in Haldane effect, everything will decrease except your pH. Okay, except your pH, everything will be decreased. Just remember these two concepts. If they ask you, all of the above are seen in right shift, all of the above are seen in left shift, except you should be answer to it. Okay, next one. About this regulation of respiration, like mostly if there is any respiratory changes or if there is any increased PCO2, it will be sensed by two levels. Or if there is an increased carbon dioxide, or you are respiring less, or you are in coma, it will be sensed by two receptors. One is known as peripheral chemoreceptor, next one is known as central chemoreceptor. As I told you, there are this simple diffusion. Simple diffusion takes place in lungs, whereas this tight bound barriers like blood-brain barriers, I told you, it will be bound by this claudin and aclodin, because in such a cases, these gases won't permeate over that. So remember, in a case of central chemoreceptors, it will be stimulated by this increase in hydrogen. Okay, increase in the protons. Okay, whereas the peripheral chemoreceptors, it can sense this increase in partial pressure of the CO2. Okay, increase in partial pressure of the CO2. And we know this peripheral chemoreceptors, it is located in the two phases. They are known as aortic body. Yeah, that is pre-Bötzinger complex. That is a different entity. That is for respiration part. Okay, fine. About for this peripheral chemoreceptors, if you see, there are two peripheral chemoreceptors. One is this carotid body. Next one, it is known as aortic body. Remember, carotid body, it will be carried, means the stimulus from this carotid body, it will be carried by this 9th nerve. Whereas for this aortic body, it will be carried by this 10th nerve. So 10th nerve will carry this aortic body stimulus, whereas this carotid body stimulus, it will be carried by the 9th nerve. So don't get confused. If they ask you, just make sure you are getting it correct. Fine. Then about this few reflexes. Okay. Then about this few reflexes. If you see about this few reflexes, one is the serious reflex which is known as Bain-Bridge reflex. For example, you say a 80-year-old female. Now you passed your FMGE examination. You passed FMGE and you are doing your internship. Now you allotted a PHC. In PHC, there will be this old age female who will be asking to give the fluids because she is feeling weak. She wants fluids. So, but you refuse because you know this concept which is known as Bain-Bridge reflex, but you know that giving more fluid, it can cause cardiac decompensation. So imagine like you are not there. Means that day you went for a party. That day you went for a party, your assistant was there. He has given more fluids. So if there is any more fluids, then what will happen is there will be cardiac chambers. This arteria will get stretched. Okay, more fluid, it will cause stretching of atria. Yeah, correct, Dr. 𝗏𝗏𝗀𝗀𝗀𝗀. Yeah, see. So there will be this stretching of atria. So once there is this stretching of atria, this Bain-Bridge reflex will activate. Once there is this Bain-Bridge reflex will activate, it will cause what? It will cause increased. It will cause increased heart rate and it will cause increased contraction. Okay, to pull out this fluids or push out this fluids, there will be increased contraction. So it is what? It is the increase in heart rate. So tachycardia it will be caused, and this tachycardia due to this increased or this distension of this atria, it is known as what? It is known as Bain-Bridge reflex. Okay, the first thing. Next one, it is known as 𝗏𝗏𝗀𝗀𝗀𝗀 reflex. Imagine you got a breakup. Okay, like unfortunately, like you got a breakup. Unfortunately or fortunately, you got a breakup after FMGE examination, not now, after FMGE examinations, and so your heart felt very hard and it released some toxins. Okay, it released some toxins like serotonins. Okay, serotonins. Once this serotonins released in extraordinary amounts, it can come and cause damage to your heart and the other vital tissues. So in such a case, like your pretty heart, it will sense, yeah, you had a breakup. Okay, it's normal, no issues. Your heart also will feel like, no, I am suffering, but I should not make others to suffer. So what it will do, this heart, it will cause tachycardia and it will cause less cardiac output, so that these toxins will not be transferred to other tissues. So there will be toxins in the heart. In a case of like myocardial infarction, there will be toxins, but this toxin should not be shared to brain and the other structures. So there will be a bradycardia and less cardiac output. So it is known as 𝗏𝗏𝗀𝗀𝗀𝗀 reflex. Okay, it is known as 𝗏𝗏𝗀𝗀𝗀𝗀 reflex. There will be this bradycardia, hypotension, and along with this apnea. So 𝗏𝗏𝗀𝗀𝗀𝗀 reflex if there is any toxins. Okay, like if there is any serotonins, capsaicin, and veratridine. Okay, so this is what this 𝗏𝗏𝗀𝗀𝗀𝗀 reflex. Next one, it is the Cushing's reflex. Okay, if there is an increased intracranial tension, means then the blood should go to the brain, right? Blood should go to the brain. So what will happen is this brain is not getting enough blood because there is more pressure. If there is more pressure into the brain, if there is more pressure, how the blood can go freely, right? The blood cannot go freely. So the body will think the brain is not getting enough blood, so will increase the BP. Okay, but this increased BP will be sensed by this brain, so which is a miscalculation. So because of this increased BP, the brain will sense there is increased BP, so I need to decrease the heart rate. So in a case of increased ICT, there will be increased BP to help or to increase the perfusion, but at the same time the brain will decrease the heart rate. Okay, the brain will decrease the heart rate. So in Cushing reflex, there will be increased intracranial tension, there will be increased BP, but decreased BP. Okay, decreased BP. And remember one point, that which of the following reflex will be having a tachycardia? It is what? It is the Bain-Bridge reflex. So the Bain-Bridge reflex will be having the tachycardia, whereas most other reflex, it will be having the bradycardia. Fine. They will give this image and they will ask you what are the phases. It is the phase 1, phase 2, and phase 3. Remember, phase 2, there will be increase in volume. The volume will be increased, but the pressure will not increase, because I told this bladder will be having a different type of epithelium. Can you tell me what is the name of the epithelium, or what is the type of the epithelium you will see in a case of bladder? It is what? It is the transitional epithelium. This transitional epithelium, as I told, it will undergo a thing which is known as plasticity or adaptation. Because of this plasticity, this bladder will distend, but there will be no pressure. There will be increase in volume. And in phase 3, there is this voiding phase. There will be increase in pressure. So initially there will be increase in volume and increase in pressure, and there will be a stagnant level. There will be where this phase 2 there will be increase in volume, but no change or no change in pressure. So it is what it is. The phase 2, it is because of this plasticity of the bladder. It is because of the plasticity. A good Dr. Harsh and Rituraj, right? Next, we'll move on to the final part. Then about this ABG analysis. You know there are multiple ways to solve this ABG analysis. Let me decode, and if you say ABG analysis from after this session, you will decode in just 30 seconds. Okay, you can decode in just 30 seconds. Yeah, if you know this well and good, that is the Rome one. Rome. Okay, this is the normal values. To remember this normal value, remember this 35, 45. The normal pH is 7.35 to 7.45, whereas normal PaCO2 it is 45 and 55. Okay, 45 and 55. So remember these two concepts, and HCO3, if you are able to remember, well and go. It is what it is, 22 to 26. Fine. Remember it is room. Respiratory means opposite. If there is a, if you see, first you need to check two things. One is what? One is pH, next one is PaCO2. pH, PaCO2, both of them they will be having the same value. 7.35 to 7.45, 35 to 45. So you remember 35 to 45 for PaCO2, 7.35 to 7.45. Okay, and see, like if pH increase, if there is increase in pH and decrease, okay, if it is C, if it is increase and decrease, is it is on same side? No, they are on opposite sides, right? These two arrows, see, if two arrows on the same side, it is, we'll call them as equal. If it is one on this side, one on other side, it is what? It is the opposite one. Okay, so remember, if it is respiratory, it will be always opposite, either increase decrease or decrease increase. Okay, fine. Whereas in a case of metabolic, both will increase or both will decrease. Okay, this is the thing you need to remember. Fine. First you see respiratory opposite, I told you, right? If there is any respiratory alkalosis, okay, respiratory alkalosis, first you see here the pH is increased, then PCO2 you see alkalosis, so the pH will be decreased. Okay, whereas we know the PCO2 it is an acid substance. In the case of acidity, this PCO2 will increase. In the case of alkalosis, PCO2 will decrease. Okay, okay, you just remember this concept. If you are unable to remember, just remember first see, if a pH is increased and PCO2 decreased, both of them they are in opposite side, so it is a respiratory. And you see the pH is increased, so it is, we'll call them as alkalosis. We'll call them as alkalosis. Next you see the pH is decreased and PCO2 decreased, both of them in opposite direction, so we'll call them as respiratory problem. And since the pH is decreased, we'll call them as acidosis. So it is what? It is the respiratory acidosis. Fine. And I told metabolic will be equal. You see pH here is increased, like we can take this to also, like so we can take this to also, or we can take PCO2 also. Like if you see pH increase and bicarbonate increase, or mainly if you just look into the PCO2 part. Okay, PCO2 part. If both of them they increase, okay, if you see this, both of them increase for bicarbonate, it is what? It is the metabolic problem. It is the metabolic one. Okay, and we know it is pH increase, so it is what? It is the alkalosis. And if both of them is decrease, then it is what? It is the acidosis. Then again it is the same side, so it is the metabolic one. And we need to see the pH. The pH is decreased, so it is what? It is the acidosis. Like I know there will be a few point of confusion. So I told the normal pH is 7.35 to 7.45. The pH is decreased here and PaCO2 is increased. If both not are in if both are in opposite directions, then it is what? Then it is a respiratory one. Then it's a respiratory. You know, if it is pH is decreased, we'll call them as respiratory acidosis. Okay, we'll do one more question. If you see the pH here, it is what? It is more than 45.45. So it is pH is increased. Okay, and then PCO2 if you see, it is decreased. So if both in opposite direction, then it is what? Then it is a respiratory problem. Then we'll see the pH. अगर pH को देखेंगे ये क्या है? Acidosis है, alkalosis. If the pH is less, we'll call them acidosis. If pH is more, we'll call them as alkalosis. So pH इधर ज़्यादा है तो we'll call them as respiratory alkalosis. Respiratory alkalosis. Yeah, good Dr. Anar. Good Dr. Shanavas. Yeah, good. Yeah, guys, we're getting it correct. Then फिर उसके बाद आगे बढ़ते हैं. Then here you can see two things. See here the PCO2, the pH is decreased. Bicarbonate is also decreased. So दोनों in same direction. So क्या है? It is what? It is metabolic acidosis. And here you see this pH is increased and bicarbonate is also on increased side. So it is the metabolic condition. फिर उसके बाद if you see this pH, so it is what? It is the alkalosis pH, so it is the metabolic alkalosis. This is the metabolic alkalosis. So if you are unable to get it, just this recorded session will be available one more time. You can just watch one more time so that you will not having any confusion. फिर उसके बाद when you will say that it is a compensated, if the pH becomes normal, then we'll call it as compensated. If you see, this is the normal pH. This is the normal pH. Whereas if you see PaCO2, it is decreased and bicarbonate is also decreased. So if there is any PaCO2 is decreased and bicarbonate also will be decreased. If you see the decrease, it is less decrease in compared to this one. So it is what? It is a metabolic acidosis. Okay, it is a metabolic acidosis. Okay, and it is what? See, the pH is normal, so it is a compensated. It is a compensated. Okay, so the final note point is that if it is on the different side, then you call them as respiratory. Then once you call them as respiratory, then you need to see the pH. If pH is more, it is what? It is alkalosis. If pH is less, it is acidosis. Then if it is both of them on the same side, then it is metabolic. Then if it is pH is more, then you call them as alkalosis. If the pH is less, we'll call them as metabolic acidosis. If the pH is normal, then you'll call them as compensated. And final part, it is the anion gap. Usually we'll measure this anion gap with the formula of sodium minus chlorine and bicarbonate. Okay, sodium minus chlorine and bicarbonate. Okay, so just remember, we'll use this anion gap between this positive and negative ions will be measured using this formula, which is known as anion gap formula. Fine. And the normal range, it is 8 to 12. Okay, there will be few conditions where there will be acidosis, but there will be normal anion gap. So this condition, they are called as 𝗔𝗔, and so it is what is known as 𝗔𝗔. So it is seen in a case of diarrhea, renal tubular acidosis, and renal failures. Whereas there will be increased anion gap will be seen in a case of methanol, uremia, diabetic ketoacidosis, and then paraldehyde, then iron poisoning, lactate, increased level of lactate, and ethylene glycol poisoning, and salicylate poisonings. So all of these conditions you can remember as mud piles. Okay, mud piles for this increased anion gap. Okay, means increased anion gap for this methanol, uremia, DKA, paraldehyde, and iron, lactate, increased, and ethylene glycol and salicylate. So iron, lactate, ethylene glycol, and salicylate poisoning. So all of them will be having this increased anion gap. Okay, just see this anion gap and the ABG one more time so that you can be well versed with it. Okay, fine. Like we'll discuss this cardiac cycle. Just remember, like before moving to the next day, just remember one thing: whatever you are doing, it is for you. Okay, and don't compare yourself with anyone else in the world because you are unique in your own way. So just have this mindset in your thoughts that you are doing it for yourself and how you are better from yesterday to the today. Okay, just remember. Okay, so just you should be better than anyone else, but you should be better than how you used to be. If you do this thing and if you keep this thing in your mind, you will shine in your life and you will come out with flying colors in your upcoming FMGE examination. And whoever didn't understand the cardiac cycle will check it out. Fine. This cardiac cycle, there is few phases. Like I'll give you a small glimpse. There will be like initially there will be this ventricular filling, followed by this ventricular contraction, and followed by this ventricular diastole. So ventricular filling, it is what it is, this ventricular diastole. So during ventricular diastole, the blood should come and it need to fill. Okay, the blood should come and it should fill. Okay, and during this ventricular diastole, there will be atrial contraction. Okay, there will be atrial contraction. Okay, and once the ventricle is filled, then it need to contract and it need to send the blood to the tissues or the body organs. Fine, it is known as ventricular systole. But just blood, it cannot go like that. We need to increase the pressure. So first phase of increasing pressure is what it is known as isovolumetric contraction. There will be a blood, you need to increase the pressure. So once you increase the pressure, it is known as isovolumetric contraction. But make sure before increasing the pressure, you should close this aortoventricular valve, which is connecting this atrium to the ventricle. Fine. Once you closed it, you will increase the pressure. Once the pressure is more than the aortic level, then the aortic valve will open. The blood from the ventricle will move into the aorta. Once the blood moves, then the valve will close. Then the ventricle will relax. then it will go into the diastole phase. This is the simple explanation of this cardiac cycle. So that is what initially there will be this diastole part, followed by this systole, and followed by this diastole part. So these are the parts you should remembering of, and this is how this cardiac cycle works. And this will be coordinated with this electrical movements and this jugular pulsations. So initially when there is this atrial contraction, then it will what? Then during this atrial contraction, it will be causing this P wave, and followed by this ventricular contraction will cause this QRS complex, and followed by this during the depolarization you will be able to get there is a formation of this T wave. The same thing will this JVP. We'll understand JVP in our medicine session. JVP initially the A wave is due to this atrial contraction, then C wave it is due to the cusp bulge, then followed by this atrial relaxation and this ventricular filling. Okay, these are the few phases you need to remember. Just remember superficial about this cardiac cycle, and S1 it is due to the closure of the AV valve, and aortic valve closes will cause this S2 heart sound. Okay, that's it guys, that's it for this physiology end. Thank you for waiting this long, and I hope you have a good lunch. Okay, yeah, me too. See you guys, miss you.